A very good morning to everyone. I'm Dr. Jamsani, a chemical pathologist from Seberang Jaya Hospital, Malaysia. Thank you for the organizer to invited me to this third China-Asean Forum on Health Cooperation. I'm sure that everyone will benefit most from this kind of conference and we can have more cooperation in future. Today, I would like to discuss on the topic of auto-verification of the result. I think most of us having the same problem when we are forced to do more with less. We need to reduce number of level and supply costs. At the same time, we need to increase our workload and to make sure that our lab turnaround time achieving better than what we are having now. And probably these are some good reasons for laboratory to look into benefit of auto-verification. I'm sure that most of the lab nowadays are implementing auto-verification, but there are also some lab that are still struggling to implement auto-verification in their own setup. We go back into some of the guidelines that are available. If I'm referring to the ISO 15189, if we want to implement auto-verification, the laboratory shall establish a documented procedure to ensure that the criteria for automated selection and reporting are defined, approved, readily available, and understood by the staff. So this is the thing, part of the criteria that need to be fulfilled before the lab can implement auto-verification. And there are also few references that we can use, basically referring to the CSI guideline that related to the auto-verification. So what actually auto-verification? Auto-verification is automated result verification, because traditionally what we do that based on mental algorithm that we decided whether the result can be released or not. It also based on single or group of analytical result. But the most important of auto-verification actually to help us in terms to identify the analytical error, pre-analytical error, and post-analytical error, because this is the final step that we can do before result can be released. Based on the CSI guideline, automated or auto-verification is automated action that can be performed by the computer system that based on criteria and logic that we establish. It can be a very simple or complex, and it can be involve many different parameters. But the most important that this system can offer the highest level of consistency and the ability to handle complex algorithm in an efficient way. So this is what the benefit that we want from the auto-verification. And instead of mental algorithm, so auto-verification is a computer-based algorithm that can be either immediate verification of result, repeat analysis, reflexive testing, addition of comment, or suggested manual step, including but not limited to the manual review of the result. So I take this opportunity to discuss of how we implement auto-verification, basically based on our experience in independent pathology, where we have managed to implement auto-verification in all our laboratory in independent pathology. So if we want to implement auto-verification, we can go into 3 different steps. The first one is planning. Second is develop, and the third is how we evaluate the system. When we talk about planning, it's important for us to assemble all the team that can be involved with the auto verifications. And second, we must be sure that we understand the process flow chart. How is the process that we're going to implement auto verification? We have to decide that what is the software that we want to use. Whether in your lab you do have middleware, or you are going to use your laboratory information system based on which system that have a better or complexity in terms of applying the rules and logic in the system. And the most important thing out of this planning is to gather all the data that related to the implementation of auto-verification. So let me discuss further what you mean by gather data on the current state. This is some of the information that required, but not limited to this. First, of course, as a pathologist or the scientist, we have to really understand the workflow. Perhaps that the auto-verification can improve our workflow based on the lean concept, for example. Second is the clinical. We really need to know the clinical that going to be integrated in the system, whether the result require further interpretive comment or not, or whether the result require further attention in terms of clinical input that we want to add in our auto-verification rules. The third is to make sure that the quality of the test, so it's defined that if let's say the test is have problematic in the quality, probably the test may or may not need to be auto-verified yet. And it depends whether the number of the tests very require, in a small number of the tests, probably we don't need auto-verification. The fourth is the technical issues. All the technicals or the related analyzer must be documented, and all information related to the interference, related to the linearities, sensitivity of the test must be gathered together to make sure that everything can be included in our auto-verification algorithm. Of course, we have to take all the constructive feedback from our customer, mainly from our clinical colleagues, to make sure that anything that any of the same feedback or comment or complaint can be prevented in future when we implemented auto-verification. And this is a teamwork. Staff must be included in all the discussion, and all the feedback given by staff must be considered when we want to implement auto-verification. So that's about the planning. The second one is how we're going. This is the major part that we need to sit down and discuss with the team, is how to develop our auto-verification rules. Of course, the first and foremost is to have the logic. We have to ask the question that what is the logic that we're going to create? When you have the logic can be transmitted or can be transformed into algorithm, and from this algorithm, we can develop the filters and the rules. And from this algorithm, filters and rules, it can be converted into the computer coding or the computer language before it can be a complete auto-verification program. So this is, for example, for a review of auto-verification of test result in the core clinical laboratory. We can have a design of algorithm that must be suited or designed or fit with the laboratory that you manage. So it could be different checking, different alarm, different delta check, limit check. You need to be incorporated into the system, and this is also based on different analyzer that you have in your laboratory. So for example, when you want to develop, you need to have some filters. So probably the filter that you can have, at a minimum filter, probably the first is the one that included the HRL index or the hemolysis artery and lipemic check, or you're looking for the interference of these three things. Second one is delta check and delta day. And the third one is delta range or the review range. So this is the main basics interference, because I'm a chemical pathologist, so I'm going to discuss more on the biochemistry test. So this is the three common interference in biochemistry testing: hemolysis, artery, and lipemic. So it's important for us to gather all the information from the pen insert to know every single test in the lab that available with the specific interference towards to each of the tests. So it must probably, we have to have some tables to tabulate all the interference and what is the cutoff that we want to think certain tests won't be reported. So this is how it's been transformed into the computer's language or program. It be transformed to each of the interference checking to each of the analyte. And this is how the examples of our tests when we cancel and we have an automated comment to each of the tests to make sure that every result are safe to be released. Because, for example, LDH is a tumor marker. So if, let's say, a very slight interference of hemolysis may interfere with the LDH measurement and may be misleading in terms of the interpretation of the result. And this is also a paper that we reported that the hemolysis also is important in terms of to make sure that we are able to differentiate between the in vivo and in vitro hemolysis. So based on our experience, we created our own alarm to make sure that every single hemolysis must be looked into, where we are not simply rejecting all the gross hemolysis sample. For example, a normal kalemic with a gross hemolysis samples, we need to trigger ourselves that there is a possibility of in vivo hemolysis instead of in vitro hemolysis, and we're not simply rejecting the sample, and instead it needs to be reported and discussed with the our clinical colleague. We also created our lipemic alert to make sure that every sample need to be tabulated, especially ammonia have a very low lipemic index that need further technical evaluation. And even the arterial alert, even though it is a patient condition, nothing much can be done in terms of result need to be reported with alarm, but it's also a good example that the A3 index can be used as a consistency check. Based on our study, the total bilirubin and A3 index have a very good correlation. So it can be used as a consistency check if, let's say, a high bilirubin with a low A3 or high A3 with a low bilirubin, there is something wrong with the analyzer. And also can be used as a decision for the total bilirubin, any sample sent to the lab without total bilirubin, but for example, is have a very high A3 index, especially for the outpatient department, probably we need to add in total bilirubin liver function test for further evaluation of the patient. The second one is the delta check and delta day. So the delta check, basically we are used based on the RCV calculation, and the delta range is the one that we are going to report what is the standard of the result can be released, because we must not be mistaken that auto-verification means that releasing only a normal result. Probably it not be just on the normal result. For a big hospital with a high complexity, if you just do the auto-verification based on normal or within the normal range, probably only 50 or 60% result can be released, because the aim that we want to get a higher auto-verification of the result, probably more than 90%. So for example, I listed a few examples how we implement the delta check. So the delta check based on the RCV calculation for the creatinine, our standard linearity of creatinine is 15 to 11,000 micromole per liter. And we choose the data range of 16 to 530. Why we choose a 530? Because this is based on the medical decision limit, and we need to have a higher cutoff of delta range, and because our hospital is a nephrology center. So it's simply that we can get a very high creatinine result. And based on the RCV calculation, our RCV calculation is 22%. And RCV can be absolute or percentage. So in our hospital, we use based on the percentage, and we choose 14 days as our delta days. But the problem with this creatinine of 22%, probably we are getting more false alarm rather than a true significant pathological changes of the patient. And probably we might think of the more important of creatinine that can give to us is the AKI alert. So what we do that we introduce our AKI alert system based on this paper, that we put a 50% of increment of creatinine within 90 days. So this is a good example that this patient came to us from SOPD department, 1 month back, the creatinine just 59, and now the creatinine become 992. Due to this high increment of the creatinine, we notify the creatinine result to the managing doctor, and the patient admitted on the same day and repeated creatinine profile and creatinine on the same day, noted that patient have AKI, and based on the deteriorating of the patient. So it's very important that this can give an added value, because creatinine is not part of our critical result, but still it can be a more proactive measure that we can notify to the managing doctor regarding the patient condition getting deteriorating. And the third one is a delta range review range. So the delta range is how is the standard of the result you're going to be stranded. So as I mentioned earlier, if you say you choose normal range, probably more result will be stranded. So it can be either extended linearity range, analytical measure range, critical result, medical decision limit, consensus of the reference range. So for example, ELP, our extended linearity is between 5 to 6,000, and analytical measure range is between 5 to 1,200. So what is the linearity range that we're going to choose? So bear in mind that the low LP also a clinical significance, so we cannot auto-verify any low LP result, and also to verify whether low LP is truly low LP because of probability of one of the reasons is hypophosphatasia or additive contamination. So that's why we do have our LP to be stranded if let's say LP less than 50, and it need to be troubleshoot whether it is due to the additive contamination. For this, for example, this patient from our dental clinic, then we notify, we add on calcium and phosphate, and we notify that it's possibility this patient might have a possibility of adult hypophosphatemia. Same go to the sodium, the linearity that we choose. We need to decide whether there is a possibility of pseudo-hyponatremia or pseudo-hyponatremia due to hypoproteinemia or hyperlipidemia, and we also need to rule out whether there is evidence of random error or systematic error. So that's important that one of it that we create our paraprotein alert, any total protein is high, we will need to add on sodium verification with direct acid that we are using our ABG analyzer to make sure that the result need to be verified whether there is any evidence of pseudo hypernatremia in the system. So back to all the filter, the most important that we want to make sure that every result require troubleshooting and troubleshooting before result can be released. So the last one is when it comes to the evaluation, to evaluate that we have to validate the auto verification rules. Probably we can use dry testing by using electronically stimulated cases based on different scenario that we stimulate, and we might sense result from the middleware to verify based on the historical data. And the most part that we need to do is the wet testing itself, means that we have to use a challenge-specific rules, whether we use unusual and abnormal patient data, or probably from the propensity testing samples or any manipulated samples, or we can have an intentionally misidentified patient result. But this is quite difficult to have all type of scenario. Probably when you go live, every single result need to be counter-check and revalidate to make sure that all rules are implemented as what we want. And when all the process is in plan, there must be evaluating process, continuous evaluating to have a periodic revalidation of the algorithm and criteria. Then we need to also review the performance of auto verification, and of course we need to revalidate all the new algorithm or criteria whenever there are any changes made to the rules. So it could be not just as simple as this, it can be more logic and more rules. For example, we can have a consistency check, auto refresh, auto interpretive command, and many more. So for example, based on this paper, most of the time that target function tank can give a lot of discordant, and this discordant require further verification whether there is a truly discordant due to patient condition or probably due to amino acid interference. That's why we create our discordant target function test verification, the system that every single result that have discordant target function test require further verification and validation by the duty chemical pathologist. For example, this patient, 2 years old boy, in the monitoring, seeing the prone jaundice condition, this patient had persistently normal TSS with high PT4 and FT3, and we discussed with our PITS endocrinologist to make sure that this patient is not misdiagnosed as hypothyroidism, and further verification, further sample send to verify patient condition, and this is notified, might be given syrup carbimazole if you've been mistakenly diagnosed as hypothyroidism. For HbA1c, we have all the complex rule. We are using HPLC method with the D100 analyzer, and we managed to do a full auto validation based on the middleware from the analyzer as well as on the LIS, so that every single samples can be auto validated when once it fulfill the chromatogram rules, and the chromatogram also will be automatically sent to us, and the duty pathologists, the chemical pathologists, or the scientists can review any of the result based on the chromatogram in our laboratory information system, and it is tremendously able to reduce our workload and workflow, or the lab turnaround time, because most of the time we have to spend most of our time to validate the chromatogram. So based on this data and based on this implementation in our opinion pathology, we are able to achieve most of our test parameter of more than 90% result can be auto-verified. We are managed to do more troubleshooting. We are managed to become more proactive, and we are managed to do more consultation to our clinical colleague instead of we just release the result blindly without doing further troubleshooting and discussion with our clinical colleague. So based on this paper, if the clinical scientists and pathologists that fail to be perceived by clinical colleagues as medical value contributor will be at risk. So it is the best time for us to implement auto verification in order for us to gain more benefit from auto verifications. So at last, why we need to have an auto verification? Because the auto verification will give a consistency in terms of LTAT. We will improve and to have a faster turnaround time. We want to reduce errors in terms of pre-analytical, post-analytical, and the analytical part itself, because the result will be verified according to the specific result, and also to have as overall result. It can be even integrate with our patient moving average. It's also important in terms of the patient safety, and we have to have a more proactive measure in terms of our contribution and our discussion with our clinical colleague. And this is also a big cost saving in labor, because our scientists, our technologists, the pathologists can concentrate to other important or other added value tasks rather than just doing or sitting for validation to most of the time doing our working hours. So our final thought is auto-verification project is never truly completed. You need to look back, review back, and upgrading the system from time to time to make sure that it fulfills our requirement. And of course, we have to enhance more and more good impact from the auto-verification. The auto-verification will remove the need to look at every result and bring the lab personnel attention to those results requiring action, so that we can do more troubleshooting, we can do more engagement with our clinical colleague. And last, even though this auto-verification enhance our laboratory efficiency, but it cannot completely replace us in the process of result reporting and decision making, because it still require our professional input to make sure that we are able to give the best. And for example, we can do our interpretive comment to be added on in every of our result. So by that, I thank you with your attention. Thank you very much and enjoy the conference. Thank you.